Assalamu alaikum, everyone. I welcome you all to the Department for Educational second virtual and the 15th Educational Grand Round. The title of today's presentation is Interprofessional Education, Improving Patient Care Across the Continuum of Education. The format of today's session is half an hour presentation by Professor Neghat Hoda, followed by half an hour for panel discussion and question answer session. I would like to introduce our speaker, today's speaker, Professor Neghat Hoda. She is Professor and Director of Health Professions Education at Liaquat National Hospital and Medical College, Karachi, Pakistan. For over 3 decades, she has pursued her career in health professions education and worked endlessly for promoting and further enhancing the quality of health professions in Pakistan. She also serves on the board of directors of International Network Towards Unity of Health. She has visited health professions institutes offering IPE, including Belgium, Ireland, South Africa, and she's keen on creating interprofessional educational models. Her other key interests are faculty development, assessment process, and modules development. At LNH, she has been engaged in the development of geriatric care course interprofessional module for PHC and biomedical ethics. So over to you, Professor Neghat Hoda.
Thank you, Amber, for a pretty elaborative introduction. I hope I'm audible.
Yes.
Thank you. Okay, today my discussion is, my presentation is, as you just mentioned, is on interprofessional education and leading to improvement of patient care across the continuum of education. So I will firstly go into the basics and then firstly declare disclosure statement first that I do not have any relevant interest arrangement or affiliation that would constitute a conflict of interest. So moving on to my overview of my presentation, my focus will be why today is, we thinking, or I am thinking about interprofessional education, why it is important, and what are the practices across the continuum and the way forward. And the forward, of course, I would like to deal more with the way forward, but I hope that I have enough time and I'll be able to manage my time well. Okay. Before we discuss why we should all be on the same, we all should have the same definition. And that is when this definition is cited that you will be seeing across in several literature. That means this IPE or interprofessional education occurs when 2 or more professions are engaged and they learn about, from, and with each other to improve collaboration and quality of care and services. So here we are talking about education and training that engages not just one profession, but 2 or more professions. So that means it would be medical with nursing, or nursing and midwifery and physiotherapy, depending on what the model that you have, and could be up to 5 or 6, but there are other examples. But then the goal is, why is this? The goal is IPCP, interprofessional collaborative practice. That means that it should be the highest delivered, provide comprehensive care, service, and deliver the highest quality of care. The whole, if they work together, if they learn together, if they work together, then they should move into practice and they would be able to work with patients and families, caregivers, and communities to provide comprehensive service and deliver the highest quality of care. So these 2 definitions, I thought in the beginning that I should sort of put forward so that, the rest of my presentation will sort of keep on looking back or reflecting on these 2. Are we on the same as the definition and goes about? Why IPE? Rising global health issues and needs. The more we learn, the more we go through literature, the more we look at the evidence, we see that the global health issues are rising. And we talk in terms of, it's not about one, but it's the increased prevalence of chronic diseases. And when we talk about increased prevalence of chronic diseases, and the needs of the countries vary, some have accessible to healthcare, some are very poor health systems are poor, and the vulnerable suffers the most. So this is giving rise, this giving the most important that as the global health issues rise, as the prevalence of chronic illnesses rise, we will find if there is the need is there for more for interprofessional education. WHO, if you read WHO and if you go into Institute of Medicine, several studies they have done, they all reach to the same. I will discuss this later, but I'm just thought give you an overview. Increased healthcare cost. We are all aware of how the healthcare, and there's no way of discussing this right now at the moment, but I mean, we are aware of how healthcare cost is sort of rising. And especially when you talk about specialist care and if you talk about tertiary care, the healthcare cost is rising. The number of tests that the investigation is needed for curing or treatment, the number of maybe hospital visits, number of length of stay, these are all leading to increased costs. And then it is not, when if you have limited, of course, income and if you have limited resources, this is an issue that we need to think is how can education help in providing such service that would reduce healthcare cost. Shortages in the healthcare related workforce. This is, main issue that is coming up, and I think Pakistan is one of the countries that is affected as well. And if you have shortages in the healthcare related force, you may have more doctors and you have fewer nurses and maybe fewer dentists and other health workforce required, speech therapists and physiotherapists. So how can IPE, and if you have a team and if you work to, and if a group that works together and provide comprehensive care, how IPE can be able to sort of not overcome, but at least look at the countries will not be able to face so much of healthcare shortages if they do right now at the moment, if they are trained together and work together and they have the same, Then the most important, I think, also is inadequate understanding and respect for the contributions of health professionals. It's more like stereotyped. I mean, well, everybody knows the role of the doctor and how important it is to diagnose and manage, but very few would respect and give respect to the others who contribute to the health of the patient or the individual and in whole health population. So we know about maybe the doctor's role. We know a little about the role maybe of the nurses, but we do not give due respect to the contribution that is made by all the other health professionals to the health of the individual or the community and such. So these are the issues that repeatedly in literature and repeatedly reminded by international agencies as well, that countries will have to and institutions will have to look into all these issues. Now, as I have mentioned, increases evidence, the most that we see increases patient satisfaction, decreasing patient's complication, fewer medical errors. So how is patient, if you look at the studies, and I will give examples of the studies that are done, but how many cases, medical errors that have come up, and maybe in one study it was that it was one of, in USA alone, it is one of the third, few medical errors is the third most that contributes to complication. So how is it that why patient satisfaction? And if we want to increase patient satisfaction, we have to see that how patients' complications can be reduced. And decreasing patient complication is one. It's a very important element of IPE. And there are studies done throughout the world, and especially if we look at the studies done in USA and Australia and UK, and they're focusing on reducing patients' complication and improving as and how it is patient's complication. Because if a patient is looked after by a group, then the whole group is involved in addressing that complication. But if the patient is looked after, not by a group of professionals, but by individuals in silos, and one after the other, he goes to one. And I can give you many examples of studies that are on that. If a patient goes for a chest pain and he enters, a family physician clinic, he enters his family physician clinic, and from there he goes to the ER, and there he goes, and then from there his patient is going from one end to the other and being seen by different doctors and different specialists. So it increases complication, and patient is least satisfied and more confused about his illness. But if the patient is seen by a group that is trained together, and they have this practice together, so there will be least of patient complication, fewer medical errors as well. So and the reports, especially if we look at the medication errors, if we look at, there are more cases given in literature about medication and how the errors has led to complications. So if there are fewer medical errors have been reported because of IPE. Teamwork and communication among health professionals. This is, if a lot of effort, a lot of research is on about teamwork and communication. What happens is that you have nurses together, if you're working on, as I mentioned earlier also, and if it is a low back pain, or if it is a chest pain, or if it is a diabetic patient, so there is a line, like there's a tension, the patient has to go. For example, a diabetic patient goes to an endocrinologist. From there, he's asked to go to an optometrist. Then he's asked to go to a dietitics or dietitian or nutritionist, and then from there maybe to a podiatrist. So if they work together, and if the communication is such, so the tension, the language that was, they are aware of the language, and they're aware, and there is less of this tension in this. And this is how interventions also. So if you see, maybe the test is repeated by different if they're working in silos, but if they work together, there will be, reduction of interventions. This is also a very important element if you're talking from the patient point of view, even from the hospital point of view, that it reduces healthcare cost. It decreases, in the sense, it decreases hospital readmission, decreased length of patient stay in the hospital. And how it does that is again the same. There are many studies that has been done, and it just shows, all these studies lead us to this, that the healthcare cost is reduced in the sense that the patient is not, the stay, there's no repeatedly we find that the patient is readmitted. As I said, if he's seen by a cardiologist and not seen maybe by another specialist, maybe a patient with chest pain also has a diabetic problem, he also has COPD. So point is, if he's seen comprehensively and provided care, so he doesn't his hospital also readmission is reduced, and the length of patient stay is reduced. So there are several studies that is on how patient stay has been reduced from maybe 15% in Australia. In some cases, it has been to 18% and maybe more. So there has been the length of patient stay is reduced as well. There is this study, comparative study of interprofessional education in global health, a systematic review, and it's in 2017. And this sort of gives across the continuum. It looks at undergraduate, postgraduate. It looks at two, undergraduate and postgraduate, and I will talk about separately about CME. But undergraduate, it's looked at the both at the developing countries and developed countries, and it looked at interprofessional education, and it sort of looked at different. It had a proper. This is a systematic review, and what they found that first there are more studies in undergraduate, fewer in postgraduate. And then it was that the studies in undergraduate, you find in more, it's mostly coming from nurses, from the nursing profession. And then it comes down into from to medicine, and then dental, and then pharmacy, so forth. And then of course there are others that who have joined in as well for language pathology and this. But then what are the studies mostly? It's about dental care, dental technology, to do with crisis management, how to solve the studies that most of the studies that that the authors looked at and that they found in their systematic review. And they had about, I think, 64 studies, and then most of them, they were about, for 65, 45 was related to undergraduate and 25 was related to this. So it was more that had to do with, of course, there were studies on interprofessional working and a team working, but then it had to do with crisis management, palliative or oncology care, ethics and professionalism, psychosocial and oncology practice. So this was this more or less the studies that were found in this particular systematic review. And then with the children in postgraduate, it was to do with children palliative care, dental care, sociology, and gerontology. So the emphasis has been that somehow or the other there's more work have been done or published maybe in undergraduates, and then fewer has been focused on this. And the developed and developing countries, it is such that developed countries had more contribution than developing countries had few, and that may be in the later slide. I'll discuss about the developed and developing. But then when we come to this, we find this that there is more to chiropractic practice practitioner, and then medical practitioner and social services. Repeatedly, we search in PubMed and we search in Google, and we came to this conclusion that there is the work that has been done is more with, and maybe because of the aging population, because of the lifestyle and the patients, these are the areas that have been, has been in this involved in this CME. There has been great support from the international agencies' recommendations as well. And if we continue, we can go back to 1980s, WHO reports, WHO framework, then very important that framework for action on interprofessional education and collaborative work, that the framework is there, WHO, and then this institute, and then the Institute of Medicine and so forth. So we find these as very supporting and cited. And so this gives, a kind of support to IPE and to institutions and governments that one has, where there is a need, there should be established. So this is kind of a background. International leading champions, as I told you, the more you do literature search, you find there are two categories of international leading champions. One is led by the government and one which is institutional led. And government, and of course, Health Canada, Canadian government and Canada, the government, it's the leading champion. It has from maybe it has the most experience in IPE, and they have published the most as well. We have it should be the UK and USA are equally in this in the category of being the leading champions. You can find that how the government of Canada supports, funds, and ensures that IPE is implemented through their financial. They have the right regulatory. We even found that in USA, as well as I told you, in the Department of Health supports, and these are the universities that sort of, in Australia, I'm sorry, I just mentioned two, doesn't mean these are the only two, is beyond. They have Monash, they have Flinders, and it's a long list, and it's because of the rural practice as well. And of course, Belgium, primary health care is also one of the most important. That is why it sort of gives you an impression that institutional can also lead innovation, and institutional can also make differences. And but of course, if it is led by the government in this, in the regional, we find that according to again some of the studies that have been done and the evidence that have been found, Qatar, Japan, Egypt, Philippines, Indonesia, and Thailand, they seem, but they do not have this kind of an integration of the complete of running a program, but they have significantly involved. You do not see countries like India. As far as India is concerned, India is more in developing leadership, and they have this famous Institute of Leadership in Interprofessional Education, and they are aimed at that, and they have created network, which maybe if I have time I'll discuss. Bangladesh, I could not research. We have very little as far as with Pakistan. The evidence is there, and it's about 2005, about the earthquake. And there are two studies that are published, and this more about IP readiness pre-validated for interprofessional learnings. So this more is about pre-validated. And then I also found something like which AKU has a diploma in dental hygiene that is also, not one, but 3-4 professions together to develop this. What we did here is also collaborating. We introduced, for geriatric care training, the idea, the whole thing was to how to improve geriatric care and how maybe in our treat center and also with the, the senior citizen primary care unit. And we had all this, as you can see, all together, work together, develop the curriculum, and they are involved in the training. The process is going on, but we, due to COVID, we have sort of a staggered, but then we are in the process of developing it into a full diploma program. So these are very scanty, not very, though, but in Pakistan we have. The way forward is something very challenging. How do we do? If in Pakistan, we are thinking in Pakistan, we have to be aware of the barriers, and the barriers are so many, but then we have to overcome this. What are the barriers? Why probably we haven't done much work on this is probably of the barriers and the challenges we're looking at. The barriers are, starting from leadership, diverse. What do we mean? I mean, in literature again, if you go back and you see the early studies done in Canada and done in US, they all lead to that you need to have leaders. You need leaders with a vision, not with a tunnel. And you don't need to have a specialist as your leader. You could be a leader from any discipline and any group. So diverse students. We have, I think this is not only Pakistan related, but this is all students coming from different backgrounds, age different, their learning style different, their attitude to issues different. So there is a very diverse student background, which you have to think about how, you can, relate to. Then there is stereotyping. Professional, everybody has its own, they're very comfort zone, and everybody is sort of, interested in its own profession and then is an expert in its own profession. And the clinical governance, there's a lot of literature on clinical governance as such that, interprofessional education seems very, very difficult in breaking these stereotypes. Training in silos for years and ages. This is the issue that we have not. We have different training in medicine. If we have pediatrics, gynae ops, everybody is training in silos. So we have not. And of course, the most important that is very lightly here is your variable academic calendar. So it's again, as I said, this is all over the world that these are the things, not faculty attitudes and availability. Why should faculty be able to share with other faculty, and why, and do we have the faculty, the availability of faculty whom we can train and do that? Logistics and financial support is important. Who is going to provide that? Is the institution supportive? And if the institution, then how much of it, the logistics, do you have enough requirements? Accreditation requirement is a major issue, but Canada has addressed this issue, and I recently had an opportunity to attend, with Indonesia as a co-host, and you'll find, I think, in Australia as well, USA also, they have this for IPE, they have made a separate accreditation. The councils, you may say, who will, who look after, and it should be more than 4 professions or 5 or 6 professions now. So the whole idea is that the accreditation is done by a separate group of people. And there is more literature coming up, and the more experiences have been added by different countries, by these 4 especially the most. Well, now that we know about the barriers, what can we do? How to move about it? And I think easy said than done. It's not easy, neither it is impossible. But then we have to stimulate networking. We have to give leadership. And as I said, this is the thing is, it's not only getting the medical specialists together or it's getting the nurses together. It's about getting the whole group of professionals who are involved and engaged in providing help to the individual. So this is the most. How do you do it? Create awareness. How do you create awareness? Maybe this is one of the forums that I have done it, but then this is not much. We have to have more repeatedly, seminars or webinars, and then identify who the leaders are, identify who who is interested, who's passionate, who understands. And then once you do that, you have a core, and has to be done repeatedly. You identify that your champions and you train your core faculty. This is again a very important aspect of it. The first 2 is something, of course, when you train your faculty, and then, of course, you have to look at the institution. You're looking at the leadership. He should be or she should be supporting this activity and ensuring that you have the finances to run these things. Otherwise, it will be next to impossible. There will be more resistance than before. How do we go about it? What is relevant? As I told you, medication error is one of that all comes to all our mind whenever we talk about this. Medication error could be several reasons. And in one of the reasons could be lack of communication between the doctor and the nurses, or between nurses and pharmacists. So it could be a host of maybe misdiagnosis and not being communicated. But then all the topics that you think about, you need to select. Don't get too ambitious and select all 7, 8 professions. You can start off with 2 or maybe 3 or 4. And you have to ensure that it is collaborative learning. It's not about just shared learning. It's not about sharing with each other about what, bringing a physiotherapist or a nurse and share what is done, but then you collaborate here, this is very important, collaborative learning. Engage them from throughout to the end. Consider introducing as optional electives. As I said, it's not, it is at the beginning, it's not, but then of course the literature also not defends this, but in situations like particularly in Pakistan, if you do this as a beginning and get results and share it, maybe this is something that we can talk about later on with diabetic patient and this. Consider the appropriate timing. This is the most difficult that I've seen in IPE. My personal experience is the timing and scheduling, because when to do it, who to do it with, should it be in first year? Should it be in which module? If it's for medical, it is maybe third year. If it's for nursing, it is fourth year. When to do it, scheduling, and how to get your faculty in that engaged. So it is. But for me, another thing is very important. And if you want respect for each profession, is to have informal learning opportunities. I mean, it pains me to see that we have, nursing schools separate, the cafeteria is separate, everything I've seen in institutions, they're not sort of involved. I mean, everything is, they're just in silos. I mean, if we have opportunities and how to bring together. Manage professional identities. This is very, very important. That means there are, you'll have, a lot of conflict arises. I mean, some would like to lead and some will like to dominate. So you have to manage these and you have to make it, feasible, and relationship has to work. Resources, make it simple. Don't make it so huge. I mean, astronomical in the sense that you make it a huge budget that it will net. We have to think, and we have to look for how we can reduce the cost and make it feasible for others. And seize opportunities for support. Now it is very, very easy with technology. I think it is not ever before that we had this opportunities. So you do this, seize opportunities for support, and you get this, you'll find a lot of international organizations or this looking, maybe they have their resources available, they are willing to share with their experiences, and you can have opportunities, and so you can move a little forward. And of course, you do all this and you don't do the last, that is commit to high quality, not gather the evidence, not even share your evidence, and you not even compile your evidence and make it to your pub, and then make it that so others can benefit from your evidence. So I think this will be very sad. So I hope, as I said, it was very challenging for me to introduce this topic because there's so much and so much is already available, and to select what I can make this into a 30-minute presentation. So I hope, Amber, I have not run over time. I tried to do that. Okay.
Thank you. Thank you so much, Professor Negat. Thank you for the wonderful presentation. Let's move on to the panel discussion. So if you have any query, please share your questions or queries via Google form. The link is already shared in the chat box. Now, I would like to introduce our panelists. We have invited two faculty. The first one is Dr. Jacqueline Maria Dias. She is Chair and Associate Professor, Department of Nursing, College of Health Sciences, University of Sharjah. She is the College of Health Sciences representative in the Interprofessional Medical Education Committee at University of Sharjah since 2019. So welcome, Dr. Jacqueline. Are you there?
Yes, I'm there, Amber.
Okay, welcome. Okay, our second panelist is Dr. Munazza Akhtar. She is an assistant professor and consultant obstetrician and gynecologist. She's the director of undergraduate undergraduate Obs and Gynae department. She also supervises nurses and midwives, and she assesses their different competencies of obstetric care. So the session is open for discussion. We have received few questions, and we will address all those questions one by one. The first one is, do we think that any blunder to patient care is also a joint negligence, or only that discipline needs to be interrogated? As we say, we all nurses, doctors, physiotherapists, pharmacists. What is your opinion about it? So open for discussion. G. Yes, Dr. Jackie, Dr. Munazza, Professor Negathoda, would you like to comment on it?
Anybody?
I believe that if we are working in a team, so it's never ever is a blame culture. Okay. So if something has happened as a team, we have to think about in the risk management forums that what has been gone wrong, how that can be improved. So it's never ever is a blame game. It's a team working actually, which can be make further improved.
Okay. So any other comment?
No, I agree with that, because the whole idea of a team, of an interprofessional team, is to work together, you need to share it and, thrash it out as to what went wrong and as to why went wrong. But doesn't mean you start and said it was your fault, you did it and you did it, and the whole, that culture and the institute you're supposed to, create is all, gone down the drain. So I think that's why we have this, so if they learn together and they work together and, they understand this.
Okay. Yes,
well, I think, Ms. Shamba, as usual, lovely to hear you, Dr. Negat.
Same here.
Nice to see you.
Thank you.
Yeah, good to see you here. I think one of the things is we have to look at very closely is, it goes back to the organization you work with. And I think that is something very, very critical in who determines whose mistake. It's always easier to put the blame on someone else, iske banduk pe dal do, on her shoulder. And you see that culture very much there. So I think it really goes back. But what I thought most, and what I've seen from experience is that, and this is even reflected in a lot of literature, is that people begin to understand and respect each other. And I think that is the crux of it. So if you respect each other, you also realize that, a mistake doesn't happen by one person. It's always, it's more of a system issue. Yeah, maybe the nurse dispensed the wrong medication, but then who wrote the medicine? It was the doctor. Who dispensed it? It was the pharmacist. So, I think it's like looking back and, having a bit of soul searching, that actually helps out. And I think this kind of an IPE culture actually makes universities begin to think right at the, level of training and continuing professional education, that's where we need to go back and look at. Thank you.
Thank you.
Thank you. Okay, so let's move on to the next question. So how can we initiate interprofessional education, especially in developing countries? And what avenues could be used for interprofessional education in a country like Pakistan?
Huge.
Yes.
Multi-million-dollar question.
So any comment from the speaker and from the panelist?
Well, I think, I'll just add, you see, there could be, I think, options are there. As I said, it could be from the government. The government has to, maybe it comes out with a policy and says that it's, like strengthening of the, even achieving the universal health coverage, talking about sustainable development goals and achieving this, and how do we reach this, and how do we so make it this available, provide the best of care, easily accessible, equity, and, so if the government, there are two ways in which with healthcare becoming more and more complex, and it has gone down to provinces, and now each province should come out with a policy. So it seems like that. But the other is, I suppose, it's institutional led, and institutions can. But then my experience is then I always say that then you have to have your some kind of pressure group with your accreditation, agency, or your, like we have right now, we have the Nursing Council, PNC, or the Pharmacy Council, and of course the PMC right now. So unless you align this, the institution, the students will also sort of have this issue as to why we are doing this. If are we going to get a job, and what kind of a job, what kind of a career we have. So these are very issues. I mean, we get very excited, like myself or Jackie can get excited and say, let's start it. We may start and we may succeed to an extent, but at the end of the day, what are we doing to other students, So we have to think in terms. So I think planning is very important, and becoming a pressure, I would like to say align somehow, make a dent into the Nursing Council or somewhere, become a partner. So that's one way of doing it.
So
Okay,
maybe
Dr.
I just want to share the experience of our department, because this IPE, the formal IPE is still lacking in our department, but informal things, informal IP activities are going on. For example, we all know that labor room is a very good potential site for IPE. In our labor room, in the morning rounds, it's mandatory for all the staffs, nursing students, midwifery students, postgraduate students, undergraduate students who are rotating in the labor room, interns and consultants, along with anesthesia resident and pediatric resident who is on duty in the labor room. They start conducting the rounds all together, the morning round. So maybe this is an informal sort of IPE. Maybe starting from that point in particular department and then taking it forwards as a formal activities. Like we have some team-based activities of obstetrical emergencies. For example, drill of PPH, in which even the porter of the labor room is also involved. So maybe starting from this and then going forward to a formal sort of IPE with a specific curriculum, specific assessment things. Maybe this is the way forward from below upwards.
Okay. Okay, so let's move on to the next question. How to ensure better coordination between health professionals and pharmaceuticals to bring down the cost healthcare?
Huge.
So any comment? Better communication between health professionals and pharmaceuticals to bring down the cost healthcare. So any comment from the speaker and the panelist?
I'm not sure as to how we can have with the pharmaceutical companies. I mean, what I see, it's about two different things, issues. It's not about practice. If we can improve health practice and how we can reduce the cost, but reducing the cost of medications, I think doesn't, I mean, if any of our panelists have any experience in that, I don't, but I think we are just talking about collaborative practice. We're talking about preparing students for collaborative practice. So I would suggest that this involves a bit, maybe a policy issue, an administrative issue, as how to, how can institutions or healthcare facilities engage with in bringing down. This is what I understand from the question, but I'm not sure if IP is related. Yes.
So I don't think it was an IP question, Amber. But I think I think if you're talking about just communication, I think it has to happen, right at the curricular level, right at the school level, at the colleges, where people learn to sit together and, study together. And I think that is something that's very much lacking back home. So, if you look at, having people sit, I mean, anatomy and physiology is the same, whether you're a nurse or whether you're a doctor. Maybe then you have more add-ons. But I think that's where, you can actually, because you appreciate other health professionals when they're sitting by you in the classroom, when they're interacting with you in an online discussion. So I think these are the things that, we need to look at very, very closely. So I think that it starts right at the grassroots levels, and then you can take it up, like Dr. Maneza said, right at the, at the obs and gynae level. So, that's where, you take it at the practice level. Thank you.
Okay. Okay, so let's move on to the next one. What first step should be taken towards interprofessional education and how it should be taught curriculum designing, creating acceptance, reaching accrediting bodies. Yes.
Well, I've said my part. I'd like to hear from Jackie and Munazza. Yes.
Sure, I could start and then Munezza can continue. Is that all right with you?
Yeah.
Yeah.
Okay, that's fine.
So I think, again, it goes back to, sitting together. I think, and sitting down right again at the, as faculty. I mean, whether you're a faculty of medicine or dentistry or, pharmacist, sitting down and realizing that, the things are the same. And I like what Dr. Nigat Huda put up in her presentation is, having electives. So why can't we have joint electives that could be, taught across? It doesn't matter, whether it's there. And you could actually do, and I think one of the areas that I'd like to point out from my experience is the area of simulation, because in simulation and, putting through a scenario, people learn different roles and learn to appreciate the role. So, you could have something in a critical care scenario, you could have an emergency care scenario, and learn to appreciate each other's roles. Nobody is, better off than the other. So I think that is the starting point, is just dialoguing and networking and understanding that there is a need. I think once we've covered that area, that there is a need, then we can move forward and, say how we're going to develop a curriculum or we're going to develop a course. But I think that understanding has to come, and that will only come if we begin to sit down and, talk and, discuss that right at the beginning. So that's my point of view. Thank you.
So when are we going to do that, Jackie?
Before we retire.
I hope so.
So I agree to all this, that actually it is the collaboration at different hierarchical level, and maybe the retreats for to bring up the significance of this. And then the next step will definitely be a synchronized competency-based curriculum. So, and the other challenge, which Dr. Nigat has also pointed out, is the faculty development in IPE. So definitely that will bring up more trust and promotion of this field. And then the last step may be the assessment, the longitudinal assessments of different IPE competencies. Maybe that is the way forward.
Okay, thank you, Munazza. I just want to add that, because of my experience and traveling and things, there are several networks that have emerged. In Africa, it's AfriPen. In Europe also, you find India. I was just searching, and they also have got INDIPEN or INDPEN, whatever, INDIPEN, meaning India Interprofessional Education Network. They have gone in that. So that is the second step. First step is that we should know each other, realize the importance and how it can improve even, the health of our population, the health of the individuals, unless we recognize and acknowledge, and then we have this dialogue, informal and formal, then we need to move forward with creating networks and thinking about broadening ourselves, and then becoming a pressure group for, maybe for policymakers.
Okay. Thank you. Let's move on to the next one. What are the role of government, institution, accredited bodies and councils like PNC, PMC, etc. in interprofessional education initiation in Pakistan?
We can go on and on that. Well, the role is very important. I mean, there is no, my experience has been for so long in this profession. Talking about PMDC and PNC, all this has been very prescriptive role. In the beginning, we experienced for nearly 3 decades or so, they describe and prescribe everything that how many lectures you do and what you do. And so it was very prescriptive. I mean, but then it's evolving in the recent, we've seen in the 3-4 years, it's evolving, but still we haven't settled as yet. So I don't want to say much on that, but they do have an important role. If you look at Australia, I said, it's the Australian Medical Council that has come up strong. Even if I was looking, I think even Korea, and if you look around, it's they have a very important role. If they come out with something that, you need to have an interprofessional education, a workforce, and then you have to be, maybe give you maybe you're inspected on that, whether that exists or not, and when how you're, I mean, that's also important. It's just like writing it down and not having anything is another issue. So I would say, yes, they have that's a critical role of our accreditation body and, councils.
Okay.
Agree and second.
Okay, so we have another question, where it is to be included in the curriculum, and what are which institutions Pakistan where interprofessional education is being taught and how to be taught? Yes.
As I said, I could not find much studies on this in Pakistan, where it is only, except for, but maybe individually we do a lot of work, but we are not publishing. So I won't say we are not doing it at all, but there could be different forms, as I explained, I mean, like I thought I read in JPMA about DED, doing it about the diploma in dentistry. Here it is, we are also in the formation of developing a course. So I think individually people are doing it, and unless they come out with concrete evidence, to support, then probably they'll publish it. So is there I mean, maybe you can add to it that how many institutions are really engaged.
So any comment from Dr. Jackie and Dr. Munazza?
No, I don't
have
about
any
it,
comment.
actually. No.
Okay, let's move on to the next one. Do you think we should have an app to make collaboration and to activate engagement on concerned specialists on patient side to make sure timely care is being provided? So any comment on it? They are talking about the app.
They are talking about the app on patient site. So what is patient site? I couldn't understand.
I didn't quite get the question.
Okay, so do you think we should have an app to make collaboration and to activate engagement of concerned specialists? That's what he or she is asking. So do you think?
I believe institutional, it should start from the institutional side rather than collaborating on a whole on some app or something like that. So,
I think we'll just add to the apps that we already have. So it's rather, it's communicating and conversation and networking right at the grassroots levels. And going back to my earlier comment, that's more important. I mean, an app is just a form of delivery. So I mean, I think, we've got Google Meet and we've got Zoom. I mean, look at us sitting in all parts of the world and still communicating, So, I mean, that's always there. The COVID-19 pandemic has taught us we don't have to be, all together in one place. We can be in different parts of the world. So I think it's more of, you don't really always need an app to get forward. What you need more is use your networking, use your contacts, join your listservs, join groups that are there, and, let people know. I mean, LinkedIn is a good way to communicate and say what you want to do. You'll be surprised by putting on some, even a message, how many people would actually respond to that and, are interested maybe on the same lines. Thank you.
Thank you.
Okay, so we take a few, one or two more questions. Can we give it a thought to start it at the level of first year formal education? Maybe physical therapy, nursing, medical technology, and a pilot subject, maybe anatomy or physiology.
Absolutely, and that's what I said earlier, Amber. It's like anatomy and physiology is the same, irrespective which health profession you belong to. So that could be an excellent starting point. What you actually need is the faculty to come together, because we're very used to, and it's like, leaving your comfort zone. So as faculty, I want to be in my comfort zone, and to get out of that comfort zone, that's where I think the issue lies. But if we're able to, network and dialogue, and at least there's an awareness. I mean, look at this. This is something very new that's, I mean, every day I get 2 or 3 article alerts of something written on IPE. So, it means that, the world is changing and people are realizing the importance of each other's profession. So I think the starting point is there, whether you use it through elective, like Dr. Nikat said, or you use it through anatomy, or you do it through a skills-based training. I think they'll all work. It just depends on, who are your stakeholders and who is actually going to be with you to, carry it through. Thank you.
Maybe for the resource poor countries like Pakistan, the resources can also be saved by this.
Definitely.
Yeah.
Okay, so we have one more question, the last. In our country, do you think nurses are not much empowered as a separate governing body, but are considered subordinates to doctors? So would you like to comment on it?
I think it's moved a long way. I mean, there may be, I mean, it's again depends on where you come from. But I think with the advent of the baccalaureate education and people's, thinking and beginning to think that, I've seen that transformation in nursing. I mean, I've been a nurse for the last 30 odd years and I've seen that transformation. So I think that is something that, you have to look at, So that image is there. It may be in some places more than others, but I think nurses have begun to start to, spend. I don't know if Dr. Nigat would agree with me and on that, but I think there is definitely a change. That is my opinion.
Yeah, I agree, Jackie. I think it's been massive. I mean, I've also been involved with, with nurses and training of nurses a long time back, starting in the 80s. I think I was with the Acusen. I was there for some time, temporary, training. But then it's transformation, massive transformation, especially in Pakistan. And I see now more and more, I was, being in public sector institution, I see the enthusiasm to enroll in a high level, to acquire higher level qualifications. So, they want to improve themselves professionally and they want to have a better image. They realize the value of, professional development. It takes time. It's not easy. Where they were and where they are now, and we hope that the next 20 years will be faster for them. The first, there's a few, I think they have overcome some of the bottlenecks.
Okay, any other comment any other last comment from the panelist? Dr. Jackie, Dr. Munazza?
No, I think it was an interesting talk by Dr. Nigat, and the fact that the questions that have arisen shows that there's a lot of interest in this area of IPE. So kudos to the group and those who are there in the audience.
So Dr. Munazza, would you like to comment? Any last comment?
Exactly.
Thank you.
So it was really a very nice presentation by Dr. Nigat Huda and bringing up the significance of such an important thing. And I'm very happy that we are currently on the way for this from at least OBGYN department at Ahan University Hospital with our leadership. With quite a lot of interest in IPE, we are moving forward from informal to formal IPE sessions now, gradually.
Okay, thank you. Now with this, I conclude the session. Thank you so much, Professor Nigat Huda, for the wonderful presentation. Thank you, Dr. Jacqueline and Dr. Munazza for taking your time out and shared your thoughts. Thank you so much. Thank you. And thank you all the participants.
I just would like to say, yes, I like to end and thank you. And I hope we continue this discussion. It would be sad that we just do this session and then we sort of, put it on the shelf somewhere and said, okay, this is not my job, we'll do it. So we need to continue this such kind of, I don't know, we need to take a second step how to move. Because as Jackie said, IPE, I mean, you get I've participated in conferences. I have very little to share what's happening in Pakistan. As I said, we have very little, but we can do a lot. I mean, we have all the professions together. We have the councils. We need to sort of shake ourselves up and, move forward. Thank you. I'd like to thank AKU and I need to thank Didi for this opportunity. I enjoyed being here and I hope participants are thinking about it to do something.
Thank you. Thank you so much. Thank you for the panelists, for the speakers and the participants. Thank you.
Thank you. Thank you so much. Thank you.
Thank you.
Thank you, Jackie. Hope to see you.
Nice to see you. Yeah, nice to see you guys.
Bye.
Bye-bye.
Bye.
Bye-bye.